Good evening. I'm Stu Tepper, and I'm happy to be on Facebook Live tonight for Yakety Yak and the American Migraine Foundation. I'm a professor of neurology at the Geisel School of Medicine at Dartmouth in New Hampshire, and I'd like to talk for a few minutes about neuromodulation as a treatment for migraine. And I'll start off by talking about the FDA-approved neuromodulation treatments for migraine. What neuromodulation is it's a way of stimulating the brain or inhibiting the brain in order to either terminate attacks of headache or prevent headache. And a variety of devices do this from different directions. And the two that are FDA approved are the transcutaneous supraorbital neurostimulator called the Cefalu Device and the single pulse transcranial magnetic stimulator called Spring TMS. There's a third device, the non-invasive vagal nerve stimulator called GammaCore, which is FDA approved for the treatment of acute attacks of episodic cluster headache, and I'll come back to that third device in a second. All three are FDA approved, though, for use. The first device, the Cefalu Device, is a device that looks a little bit like a rhinoceros horn or a unicorn horn, and it's non-invasive. That means it's portable. A person puts it on the forehead, and there are sticky pads that serve as electrodes, and the device is FDA approved for both the prevention of migraine and the acute treatment of migraine, the as-needed treatment of migraine. And the way the prevention setting works is that a person will wear it for 20 minutes a day, turn it on for 20 minutes a day. And over 3 months, the device has been shown to gradually reduce the number of migraine days. The other setting is the acute setting, and in that setting, a person would turn it on when they have a headache and wear it for about an hour. So you don't need to wear it all the time. Just wear it 20 minutes a day for prevention, an hour a day on an as-needed basis. And that device requires a prescription. They all do, but it can be ordered online once you have a prescription from a provider. The second device is called Spring TMS, and it's a magnetic device which is portable, and all of these are rechargeable. And the STMS device is put on the back of the head, and after booting it, person presses a button and it pulses a magnet into the back of the head, and that's done 4 times in the morning and 4 times at night. And 4 pulses twice daily is the treatment for prevention of migraine. And again, over about 3 months, that reduces the number of days with migraine. It can also be pulsed on an as-needed basis for migraine as an acute treatment, and people generally pulse 4 times for that to a maximum of 17 pulses in a day. Both of those devices, the Cefalu Device and the Spring TMS device, are approved for both the preventive treatment of migraine and the acute as-needed treatment of migraine. Both are FDA approved. Both require a prescription, and neither has any significant side effects. The FDA has described these devices as non-significant risk devices, meaning they really don't cause significant side effects. And that's the great advantage of neuromodulation over drugs. All the medications we have side effects. These devices really don't have significant side effects. The third device is the non-invasive vagal nerve stimulator, or GammaCore. It looks a little bit like a Norelco razor, and the way that works is that people put gel on the top of the device, put it on the neck over the vagus nerve near the carotid, and turn it on, and it stimulates for 2 minutes. And then the person repeats that twice more, and that will, if the patient is lucky and it works, that'll terminate an attack of episodic cluster headache. That device shows promise in preventing cluster headache. It shows promise in the acute treatment of migraine. And currently that device is before the FDA at the time of this Facebook Live, which is January of 2018, is before the FDA for the acute treatment of migraine as well. Again, that device requires a doctor prescription, and again, it's a non-significant risk device. Now, how do these devices work? Well, we think that each one goes into the brain on different pathways. The Cefalu device goes in over the supraorbital nerve, so people feel tingling and pulsing when it's on. The Spring TMS is a magnet that goes in through the back of the head, goes about halfway front to the front of the head and not below the neck. And the gamma core device goes in through the vagus nerve. And all of these devices go into the brain and then slowly inhibit the pathways that are associated with headache when they work preventively. And in a quick manner, they reduce the headache on an acute basis. It may not matter which way they get in. And there are other devices that are in development that I want to talk to you about. One of them, which is before the FDA, is a device which is contained in headphones that are worn with little cones that go in the ear. And that device is called the Scion Neurostim device. It's a caloric vestibular stimulator. That device works by heating and cooling the vestibular nerve. And when worn 20 minutes once a day or twice a day, it has been shown to prevent migraine. That device is also a non-significant risk device, and that device is currently before the FDA for the prevention of migraine. What's interesting now, if you think about it, you have one device, the Cefalu device, which works by electrically stimulating the supraorbital nerve. You have one device, the Spring TMS, which works magnetically and gradually reduces the number of headaches. Another device which electrically stimulates the vagus nerve. And then the caloric vestibular stimulator worn in headphones heats and cools the vestibular nerve. And once again, the form of energy that goes into the brain may not matter as much as where the signal goes into the brain. You may have a number of different routes to get to the same outcome. There's another device called Neurivia Migra, which is being tested as an acute treatment of migraine. And this is a device that looks like a patch and is put on the arm or another distant area and turned on at the beginning of a migraine, again, worn for anywhere from 20 minutes to an hour, and that's being worked out. And in one study that was published in 2017, it looked like it could terminate migraine attacks. So this device is being studied currently in the United States as an acute treatment for migraine. And it's a non-painful stimulator of usually the arm. And that appears to be a way of gating the migraine and turning the migraine off. There are also devices that are in development that would simultaneously stimulate the supraorbital nerves and the occipital nerves at the same time to acutely terminate migraine. And then finally, there are devices in development which involve surgical procedures. For example, there is a device called a sphenopalatine ganglion stimulator, or Pulsante, which is approved in Europe. It's a very small device, about this big, that's put in through the mouth by a surgeon and screwed in above the teeth. And a stimulator sits in an area of the skull over a particular set of nerves, the sphenopalatine ganglion. And there are no external wires and no batteries, and it can take less than a half an hour to put this device in. And then the patient can use a remote controller, which has the battery and the electrical power, can be recharged and programmed, and place the device over the cheek and turn on the stimulator inside to terminate cluster headache. The device has been shown to be effective in both stopping cluster attacks and chronic cluster headache acutely, and in preventing chronic cluster headache. And there are over 400 patients that have been implanted with this device in Europe and in the United States. And the device is likely to be presented to the FDA for an approval this year or next year, as a large study on acute treatment of chronic cluster headache attacks in the United States has been completed. So that device is the SPG stimulator, or the sphenopalatine ganglion stimulator, or Pulsante. Older neuromodulation devices include the occipital nerve stimulators, which used to be inserted at the back of the skull with a wire that would go down into the chest with a battery and a power device in the chest called an implantable programmable generator. The occipital nerve stimulator devices would remain on continuously to prevent migraine, but there have been a number of side effects associated with occipital nerve stimulation implants, including migration of the leads, breakage of the leads, battery depletion, and infection. And in Europe, the approval for the occipital nerve stimulators for migraine was taken away in 2014. So there are a significant number of problems in terms of occipital nerve stimulation as a reasonable treatment for the prevention of migraine. And it clearly is better if one can use non-invasive neuromodulation devices that don't have significant risk. Our biggest challenge with these devices has actually been getting payers to pay for them. They're not terribly expensive, but they're expensive enough that most people can't easily afford them. They're cheaper than designer medications that are brand name, but they are still more expensive than generic drugs. And it's a hope that we can convince the payers of the importance of these techniques for treating migraine, because most people want to use them rather than medication given the choice. I think at that point I'd like to stop and take questions if we have any. So let's see. I see some on my list here. We'll start with Jenny. I've had migraine since I was 4. Oh, actually, it's not a question. Let's see. I'm looking for questions. Let's see. A lot of discussion about Botox and whether Botox is a reasonable option. It's a very good option for prevention of chronic migraine and is given every 12 weeks, and it requires 2 or 3 cycles to know if it's going to work. One of the questions about neuromodulation in comparison to Botox is it's probably cheaper to do neuromodulation than Botox. Both the Cefalu and the Spring TMS devices are less expensive if we can get our payers to pay for them, and it may be reasonable to try them before Botox. I can encourage you to go to the American Migraine Foundation website. Neuromodulation is discussed there, as well as the other new therapies in development. And I think it's been a very interesting discussion and a very exciting area for migraine. So I want to thank you and have a great evening.